Thank you so much. It's a pleasure to be here today, and I'm happy to be speaking to you from the standpoint of serving as the scientific lead for the American Heart Association's work on cardiovascular kidney metabolic health, as well as the chair of the American Heart Association Council on Lifestyle and Cardiometabolic Health. So I'll be giving some perspective on cardiovascular kidney metabolic health and priorities from the standpoint of I won't speak for the American Heart Association, but the work that's going on in the American Heart Association. So I have no relevant disclosures. And really the main objective here is that by the end, you'll be able to kind of describe the rationale, which I think has been really highlighted nicely by all the preceding talks, but then also the definition for this construct of cardiovascular kidney metabolic health. I'll make sure I kind of reinforce some of the qualitative and quantitative approaches to assessing risk, which is a really important first step in this process. But then, as the title described, I'll focus on 5 key national priorities in the efforts to improve CKM health in the overall population. So there were 2 major scientific papers that came out in circulation this past fall, a presidential advisory and scientific statement on cardiovascular kidney metabolic health that have generated some discussion. My good friend Salim Virani was actually an important part of that work. And I think the key question is, why is there such an emphasis on cardiovascular kidney metabolic health? So I think this has been highlighted in the many talks, but I'm going to go ahead and kind of make a fine point on this as the final talk. So first of all, there's really this very important pathophysiologic close interplay among metabolic risk factors like obesity and diabetes and metabolic syndrome with chronic kidney disease and the cardiovascular system. They're all intertwined. Importantly, we've seen a very significant shift in the causes of heart disease risk in the population over the last several decades, and we have now an increasing burden of this obesity and diabetes and cardiovascular disease, but also earlier and earlier presentations with cardiovascular disease. Now, the big clinical consequence of this confluence of factors is premature mortality. And it's premature mortality that's primarily due to cardiovascular disease. And this is actually also the major driver of disparities in cardiovascular rates and outcomes in the population. So, major challenges, but a key opportunity in that we have better scientific understanding, and we now have multiple new approaches and therapies to impact metabolic, kidney, and cardiovascular outcomes. I don't know if you've seen this slide yet, but this is basically a hierarchical clustering analysis that really describes what's the primary cause of cardiovascular risk for individuals in the population over the last 25 years. So if you start back in the very beginning, back in 1990, you can see these purple bars and these blue bars represent hypertension and hypercholesterolemia. If you go over time to almost 2015 or so, you can see that those have decreased over time as the primary phenotype of risk for individuals. On the other hand, you see the orange and then the blue have expanded over time, and those are obesity and chronic kidney disease, and the red has remained stable, which is severe hyperglycemia. So in general, we're seeing less of hypertension and hypercholesterolemia as the primary phenotype, and more of obesity and CKD and hyperglycemia as the primary phenotype of risk. And we, of course, have seen these maps that show that we have these intertwined obesity and diabetes epidemics, that where we see one, we see the other. But this general issue tells us there's more than that that's going on pathophysiologically, a deeper interplay. And that's really what's represented in this conceptual diagram. All of it starting with excess and dysfunctional adipose tissue, compounded by, as was described in an earlier talk this morning, ectopic fat deposition, including in the liver, MASLD. That potentiates these central processes of inflammation and oxidative stress and insulin resistance and vascular dysfunction, all of which have multiple impacts. They contribute to the development of metabolic risk factors, hypertension, dyslipidemia, diabetes, the broader metabolic syndrome, also to chronic kidney disease. And then all of these processes together increase the risk of various forms of cardiovascular disease. This really leads to the broader definition that the American Heart Association has recently defined for CKM syndrome is really just a health disorder that's due to these connections among heart disease and kidney disease and diabetes and obesity, with the consequence of that being poor health outcomes. Now, when we talk about poor health outcomes, there's several ways you can look at that, but the most important way to look at it is premature mortality. So if you look at the individual components, so if you say severe obesity, we see a survival reduction of 8 to 10 years. Diabetes, 13 to 14 years, and earlier diabetes onset with greater survival reduction, and CKD stage 4 versus EGFR greater than 60, a greater than 20 years survival reduction. But in reality, in clinical practice or in the real world, we don't see these individually. These occur in confluence. So what happens in confluence? So when we see these components together, diabetes over the course of 10 years, a nationwide sample mortality risk about 8%. Chronic kidney disease, a little over 11%. But when you put them together, the sum is more than the parts. So we see a greater than 30% 10-year mortality risk when we put them together, indicating the importance of this confluence of these factors happening at the same time. Now, what does this mean in terms of the overall population mortality? Well, population mortality trends over the last 5 decades have been steadily declining. All kinds of great stuff. Smoking cessation, getting a better handle on cholesterol, starting to address blood pressure. But now, in the last decade, we've seen a complete plateau and recently the beginning of an uptick. And this is largely believed to be due to this emergence of CKM syndrome, obesity, diabetes, and CKD. We also know this is not borne proportionally in the population. We know there are certain segments of the population that are having more challenges with diabetes and with metabolic syndrome and chronic kidney disease and also with quality of care. So if we really have an interest in improving equity in outcomes of the population, addressing this is going to be a key aspect of that as well. So, recognizing this public health crisis, the American Heart Association convened a multidisciplinary science advisory group. It was led by, co-led by myself, a cardiologist, Cheryl Chow, who's a pharmacist, and Janani Rangaswamy, who's a nephrologist. Again, reflecting the fact that we're dealing with a multi-system challenge that needs a multidisciplinary approach. It also had a multidisciplinary science advisory group of amazing individuals, including my friend over there, Salim Virani, down here in the corner, who seems to never age, as well as lots of other really wonderful folks who provided that great multidisciplinary perspective for this. Adult doctors, pediatric doctors, different disciplines, scientists, as well as clinicians. There was an initial focus on really providing a clinical compendium and action plan, kind of summarizing where we are and where we need to go, but then also bringing in stakeholders to achieve broader clinical consensus, and then now we're in part 3, and I'll describe parts of part 1 and 2, moving towards adoption and implementation in the broader population. So, what are these major areas of emphasis in this action plan for optimizing cardiometabolic health? So, there's priorities in CKM health I'm going to put into 5 buckets. It's a little bit artificial, but just for the sake of giving you something for us to kind of focus on. So number 1, early detection of risk to support enhanced prevention across the life course of cardiovascular and kidney disease. 2, considering SDOH in our care models for cardiovascular kidney metabolic health. 3, developing systems to reduce fragmentation of care. 4, attention to some of these historically underaddressed conditions, and I'm going to particularly focus on obesity and chronic kidney disease as conditions that have really gotten a lot of very little attention from a prevention standpoint over the years. And 5, a greater focus on multi-system and holistic approaches to care. So now I'm going to give you a couple of bullet points on each of these major priorities. So the first priority is the concept of early detection of risk and also life course prevention. And this really provides the rationale for what we call CKM syndrome staging. So what is the staging about? So the staging is meant to reflect this progressive pathophysiology and the conceptual framework I showed you for CKM syndrome. Now, importantly, the goal of this is to improve the identification of these under-recognized clinical conditions that are often initially asymptomatic, but they confer increased clinical risk over the long term. And importantly, this is a good example that 90% of individuals with chronic kidney disease, for example, are unaware of the condition. The stages are all meant to represent higher levels of absolute risk that say, hey, with greater absolute risk, you're going to get more bang for your buck, so more intensified therapies. And there's a primary focus on cardiovascular disease to define the axis of risk, as well as on kidney failure, but it's important to recognize that in people with kidney disease, CVD is still the primary cause of mortality. Again, very importantly, Each of these stages then represents a window for preventive intervention with the goal of preventing progression to the later stages, and also supports the concept of stage regression with marked lifestyle change and or weight loss. So here are the stages, as you may have seen in some of the publications. So stage 0 is representing those individuals who have no risk factors yet. There's a focus here on primordial prevention, preserving cardiovascular health, as shown here in this Life's Essential 8 figure. Now, that often progresses to stage 1, which is excess and or dysfunctional adipose tissue. That's really the precursor to so much of what comes later. Stage 2 are those metabolic risk factors like hypertension, metabolic syndrome, CKD, diabetes, hypertriglyceridemia that mostly come from that excess and dysfunctional adipose tissue that themselves are the precursor to the development of subclinical cardiovascular disease in stage 3, where we also have the risk equivalence of either high predicted risk using our new risk calculator or very high risk CKD. And then stage 4, individuals who have clinical cardiovascular disease and CKM syndrome. Again, representing the natural progression across this CKM syndrome progression, giving us an opportunity for stages for prevention, and also giving us a focus for stages for regression as well, and seeing where we need to intensify our approaches to care in the population. We also recognize various risk-enhancing factors that can influence individuals' likelihood of progressing along the CKM syndrome progression spectrum. So chronic inflammatory conditions, more adverse social determinants, South Asian ancestry, sex-specific risk-enhancing factors. You just heard about mental health disorders, sleep disorders as well, inflammatory markers, and family history. We've also used this opportunity to update the approach to CVD risk prediction by the American Heart Association because of this recognition of CKM syndrome. I've said the fact that we have not just atherosclerotic cardiovascular disease, but various forms of heart disease that are occurring. So this brings in now ASCVD in our prediction, as well as heart failure and total cardiovascular disease. Earlier presentations, now we have prediction from age 30 to 79, a broader range, assessing 10 and 30-year risk, which the 30-year risk being particularly important for younger adults. Adding these CKM syndrome components to the model, and then adding social determinants in the model as a really important aspect, and actually removing race, but still seeing great calibrations in all demographic groups. And it's important to recognize this is complementary to the qualitative approach. So in stage 3, those individuals with high predicted risk are risk equivalent, and in the earlier stages, higher risk can indicate greater benefit for preventive therapies. This is going to be key as we move to thinking about not just statins with our risk models, but thinking about other agents. And Ambrish Pandey and others have done wonderful work in this regard, highlighting the use of risk scores to identify who could benefit the most from CKM therapies. Now, to identify people who have risk, identify people who are in stages, to identify people for the risk scores, you need to do actual screening. So we have a systematic approach to screening with the intensity of the screening and the frequency linked to individual CKM stages. So social determinants, BMI, metabolic syndrome, liver fibrosis, as was described with the FIB4 and UACR, all of these are things that are being systematically done, not just for adults, but also for youth, because we know we're seeing the emergence of this earlier and earlier. Key priority number 2 is considering social determinants of health in CKM syndrome care. So we know about the racial ethnic differences in CKM syndrome, and we know that those are largely driven by social determinants of health, and that they impact these social determinants in multiple aspects of the lived experience for people with CKM syndrome. And we are now having this growing array of therapies, but the people who have the most burden of CKM syndrome are also the people who are least likely to get access to these therapies. So we need to really be thinking about CKM syndrome, so our social determinants, as we consider care. How does social determinants impact this? Well, they impact the whole life course of CKM syndrome. First of all, we see that they impact at multiple levels our health behaviors. Who's going to actually be able to, we've heard about this multiple times, so I won't get into it in depth, but they impact multiple aspects of health behaviors. But then they impact not only the development of these CKM risk factors, but the likelihood of detecting these factors as well. So the screening. Additionally, they impact not only self-care, but engagement with the healthcare system. And through this cascade, they will generally lead to a higher likelihood of having CKM syndrome complications as well. When we think about social determinants, of course, it's important to think about them at multiple levels, at the societal level, community level, interpersonal level, all of these working together to impact health behaviors. We have different levels of individual predisposition, but all of this should be nested within this broader socio-ecological framework. So as we're optimizing this, we need to think about CKM social determinants in all aspects of optimal CKM care. So how is that lending itself to our approach? So the approach that we've really highlighted is systematic screening for social determinants of health using validated tools. Secondly, the PREVENT model that I just described now includes a place-based measure of social determinants. And the question is, what other values are going to be included over time? Integrating these social determinant assessments into our clinical care workflow and the EHR, and then also having individuals on the care team who can actually help to address these when they're found, community health workers and care navigators, and leveraging existing community resources and programs for those with adverse social determinants of health. So really integrating it into our workflow. Key priority number 3 is reducing fragmented care. So we know that when we have individuals who have multiple systemic challenges or multi-system disease, they're often going to see multiple providers. So they're going to be seeing the primary care physician, of course, but also the cardiologist and the endocrinologist and the nephrologist and other aspects, members in the care team, nurses, diabetes education specialists. That often leads to challenges with navigation, that can lead to things falling through the cracks, that can lead to challenges in terms of communication and collaboration, and often, as was said earlier, people sticking to their own silos, say, you take care of that, I'm taking care of the cardiology side, you take care of the endocrinology side, as opposed to thinking about things from the standpoint of the whole patient. And really there's a need to move forward from just thinking about these individual silos and individual risk factors to a patient-centered approach. What is the patient seeing, and how can we harmonize that in terms of their specific risk factor portfolio, but also their coordinated care, and also thinking about the broader social context. So Neha described beautiful work with regards to thinking about interdisciplinary care models, and really her and others, we're starting to see this emerging body of work for the ways that we can think about approaches to interdisciplinary care. We put forward 2 models, a value-based and a volume-based care model. The value-based model that really supports interdisciplinary care when we see a confluence of these risk factors, bringing together an interdisciplinary team with a CKM coordinator that can really help overcome that limited time that providers have to do all this coordination on their own, and then them partnering with PCPs and with patients in the journey to optimal CKM health. But then that's for individuals who have this confluence of factors, but the higher risk individuals who need to really be focused on by a direct specialist, that's that making sure we have the targeted referrals for those individuals to nephrology, endocrinology, and cardiology, the CKM coordinator assisting with navigation across specialists, and then really the flexibility to rely on telemedicine more or less as needed depending on the density of subspecialists in an area, or to rely more on value or volume-based care approaches as the health system requires. Key priority number 4 is having a greater degree of attention to historically under-addressed risk factors. And I am just going to focus on, everybody could pick their own, but I'm going to focus on a couple, which is really obesity and chronic kidney disease. So obesity, is really, as we've described, at the root of CKM syndrome, but it's really actually only effectively addressed in a striking minority of clinical encounters. We are seeing it come up more now because people are prescribing more GLP-1s and double incretin analogs, but there's so many ways in which we are not actually doing that effectively. And the causes are multifold: our training and our knowledge, the weight bias and stigma that go on in the environment, particularly our usual approach of thinking about this as an individual failing as opposed to a systemic challenge. Poor reimbursements, poor coverage, limited time and resources, but there's a growing interest now as people see this as a modifiable risk factor, and we need to kind of equip people in this regard. Chronic kidney disease, similarly, as I said, 90% of individuals with a diagnosis are unaware, but we know that the therapies that reduce CKD progression also reduce CVD risk now. Kidney health is equaling to heart health. So early detection and these therapies are going to be key for optimal prevention. So in the context of obesity, we do know this, that taking a non-judgmental approach to the weight loss discussion is really going to be most effective. This is a nice work from my colleague Kim Gudzune, looking at individuals who are based on their judgment level or discussion level, and they see the individuals who are not judged but discussed effectively had a greater than fourfold higher likelihood of clinically significant weight loss than individuals who were not discussed and in the judgment category. We know that the approach is well proven. So the Stop Obesity Alliance has a nice toolkit for using these 6 A's for the appropriate approach to addressing obesity in clinical encounters. This is something that we're not usually taught in our classes, but this is something that needs to be part of our curriculum for how we're engaging effectively, but in a way that reflects the complexity of obesity, the fact that this is a systemic challenge and not just an individual failing, and also is more likely to reduce the weight bias and stigma that's actually quite prevalent in clinical environments. This is the pathway to getting us to greater degrees of obesity assessments and partnerships in clinical environments. CKD is something that we're also strikingly under addressing. And one of the reasons is because we're not screening for it appropriately, particularly recognizing the fact we need to look at not just eGFR, as represented over here, but also looking at urine albumin-to-creatinine ratio, because the two of those together, you can see some individuals with moderate eGFRs still they fall into this pink or red category of very high-risk CKD based on their UACRs. So we need to put those two together. And it's important. That actually reflects risk not just for kidney failure, but it's for cardiovascular events and also for all-cause mortality as well as other disease happenings. So this really needs to be a key focus, and we emphasize systematic screening for that in individuals who are in CKM stage 2 and above. Key priority number 5 is a focus on multi-system and holistic care. So it's not going to be sufficient any longer to focus on individual risk factors alone if we really want to prevent heart and kidney disease in the modern day. We need to think about multiple interrelated risk factors in CKM syndrome. Now, there's 2 ways of thinking about this. One is lifestyle, which we've talked about its importance, and targeted pharmacotherapy for residually uncontrolled risk, and also thinking about it from the standpoint of these increasing array of CKM therapies that you've heard about with multi-system benefits. So I'm not going to spend too much time going over them individually. I will talk about lifestyle therapy, lifestyle plus pharmacotherapy. This is the STENO2 trial, which really indicated, so we know in the past that just doing aggressive glycemic control is not associated with enough reduction. It doesn't actually associate with much in the way of macrovascular risk reduction in diabetes. But in STENO2, people with obesity, overweight, and diabetes and albuminuria, lifestyle change with targeted pharmacotherapy to reach their goals, we saw over the course of greater than a decade, almost a 50% reduction in mortality and almost a 60% reduction in cardiovascular events. So really emphasizing the need for multifactorial risk factor control. And we also know we have this growing array of really impressive CKM therapies that we need to employ appropriately. SGLT2 inhibitors with glycemic benefits, but also reductions in major adverse cardiovascular events, cardiovascular mortality, heart failure hospitalizations, and kidney events. Finerenone, with the reductions in kidney disease, but also that kidney disease reduction translating to cardiovascular risk reduction. And we know we're about to see at the European Society of Cardiology positive results in HFpEF and heart failure with mildly reduced ejection fraction with finerenone as well. GLP-1 receptor agonists and the broader incretin analogs with marked weight loss, this newer generation, improved glycemic control, improved metabolic risk factors, reductions in cardiovascular mortality, and the recent FLOW trials showing a reduction in chronic kidney disease progression and improvement in outcomes in that population. We know that in people with existing cardiovascular disease, these agents, the SELECT trial showed a 20% reduction in major adverse cardiovascular events. We know that in heart failure, we're seeing some important improvements in functional status for individuals in the STEP-HFpEF trial, but importantly, I highlight here the N2-proBNP. I was just talking with Ambrish outside about the fact that usually with weight loss, N2-proBNP goes up because it's usually suppressed in obesity, but in STEP-HFpEF, it went down, seemingly indicating something positive happening from a cardiac standpoint. This seems to be somewhat verified by the recent SUMMIT trial that's going to be coming out soon this year that showed a 38% reduction in risk with tirzepatide and HFpEF with obesity. And Brendan Nguyen and colleagues have shown that using multiple agents maybe has a collective impact on risk, but Obviously, we have issues around cost. We have issues around polypharmacy. So we need to balance that in terms of who we're thinking about. So that's where the staging concept is going to be helpful as well, that those individuals with higher absolute risk are probably going to want to be where we prioritize thinking about combination therapies to achieve that greater risk at the cost of healthcare costs and polypharmacy. I'm not going to go over this, but this is basically algorithms for CKM syndrome management. If you're interested, they're in the papers. Basically focusing on interdisciplinary care, addressing obesity, addressing various risk factors, thinking about a comorbidity-based approach for diabetes care and CKD progression, and then more combination and intensive therapy in those with higher risk. And very similarly for those in stage 4 with existing cardiovascular disease, a similar approach, but just greater intensity in those with existing cardiovascular disease. Now, there's broad evidence, there's broad guidance, we know where we need to go. How do we translate this guidance into improving CKM health in the actual population? So, as I mentioned, there's going to be a focus here on starting with the clinical compendium and action plan, clinical consensus, but now moving to the approach to adoption and implementation in the public. There's an 8-pronged patient-centered implementation focus that starts with a focus on social determinants, increasing access to pharmacotherapies, addressing key research gaps, a focus on interdisciplinary care, CKM education, enhancing obesity management, improving approaches to implementation within and across health centers, and also more broadly, supporting healthy lifestyle communities. Each of these has been a focus of a talk today, so I won't go into any of them in depth, but I'll go ahead and just focus a little bit more on 3 of these areas. One is the concept of implementation. So as I've mentioned, this is a key focus area for the American Heart Association. So there is, starting this summer, going to be a 4-year implementation program focused on taking the CKM health guidance from the Presidential Advisory as described and translating this into 150 health centers over the course of those 4 years with CKMH support measures and center-specific performance assessed. There's going to be a certification program, a focus on centers of excellence in cardiovascular kidney metabolic health, and really trying to basically use this as a mechanism to optimize their approaches to CKM health in populations, using the broader Get With The Guideline slate of hospitals that could start domestically, but also have the potential to act globally. So this is going to be an exciting next step that's coming up over the next several years. Obviously, for a lot of these therapies, it needs to be a focus on access to pharmacotherapy. I was just talking with Khurram a second ago about mechanisms to make sure we're making that happen. So there's a lot of advocacy efforts going on along those roads as well. Obviously, on the health teams, having pharmacists and social workers to facilitate access is important, but we need to advocate at the policy level, and we need to make sure that we're basically including all of the stakeholders in discussions, and there's a lot of work going on from that standpoint to really advocate for policy change advocacy measures. And I think the toughest nut to crack overall is going to be supporting healthy lifestyle in communities. So we know that if we want to think about this from the standpoint of getting at the root causes, think about this from the standpoint of addressing the life course prevention, particularly starting in youth, and also think about this across diverse settings and communities, we need to support this in various community centers using multi-level partnerships. So AHA is in a lot of discussions about how to partner with some of the great work that's happening in the community and with stakeholders, and to really try to see if we can use these to advance cardiovascular health across the life course, and also with a focus on equity and advancing the opportunity for achieving cardiovascular health across diverse communities. The goal is to move from an individual health factor situation, move from our individual silos, and to think about a patient-centered implementation focus, looking at what the patient is seeing in terms of their risk condition, in terms of their coordinated care needs, and in terms of their broader social context. And that's really the vision for implementation overall, a holistic approach to patient-centered implementation. So, finished a minute early. In summary, CKM Health is really going to reflect this interplay between among metabolic risk factors, chronic kidney disease, and the cardiovascular system. And it's really quite prevalent. I didn't really get into the data epidemiology. I'm sure Ambrish did wonderful work in that regard, but greater than 90% of the population falls somewhere along this spectrum, stage 1 to 4. And that's not meant to be defeatist. That's meant to say this is a focus on how we can optimize health to prevent the development of disease that will happen in the absence of action. Importantly, is a disproportionate burden in those with more adverse social determinants of health. And most importantly, it's a key predictor of premature mortality and disparities in mortality. We also know that this fragmented care impacts clinical outcomes in CKM syndrome. So there's been several steps that reflect the priorities that I've just described. So definitions for CKM syndrome, but also approach to staging and screening that's really meant to promote enhanced risk factor detection and prevention across the life course. A focus on updating the prediction model to reflect the needs related to CKM syndrome, overarching considerations of social determinants, as well as a focus on interdisciplinary care, a greater focus on addressing under-addressed risk factors today, and on broader holistic care, and importantly, the framework for optimizing CKM health in the overall population. So thank you so much for your attention at the end of a long day, and it's really, I don't know what we're gonna do for questions, but sure.